Hello, everyone. Welcome. I hope you're all doing well today, I should say, depending on where you're joining us from. If this is your first time at an In Touch event, we would love to hear about how you heard about our institute or the series itself. But the In Touch is a series of virtual presentations by teachers and developers from each of our institutes, both the Upledger and the Barral Institutes. We like to give you the latest information pertaining to our manual therapies, and we really hope that these presentations will either get you excited about enhancing your health or the health of your clients. We'll open these events to anybody who would like to attend. I mean, you can. I hope that there's many therapists on tonight, but also I hope somebody heard about this from their therapist, maybe their child, anything they can learn that will be helpful for their little ones. So you're welcome to pass this on at a later date. Everyone here, since you are registered, you will receive the recording at a later date as well. As soon as our team gets the content, edits if we need to, and does whatever we would need to, we're going to send you that. You're welcome to send that on to anybody. Maybe you have a cousin with a little one out, a few states over, and you've been telling them how this work could impact them, and you're a therapist. Send them this presentation from Jean Ann. That's part of the reason why we created this series. So Jean Ann Zollars received her BS from Ithaca College, MA in Rehabilitation Technology from San Francisco State University, and a DPT from Rosalind Franklin University of Medicine and Science. Using integrative physical therapy model, she treats both adults and children through her private practice in Albuquerque, New Mexico. Her special devotion to children of the world led her to be trained in neural developmental treatment and to write Special Seating, an illustrated guide. That was published in 2010. In 2024, Jean Ann released Pediatric Manual Therapy, Visceral and Neuromeningeal Manipulation, Volume 1. That is a two-part series. The second volume will be coming out in early 2025. Guided by the question, is there more we can do to help our children? She discovered visceral manipulation in 1991 and began teaching with the Barral Institute in 2004. She now teaches visceral manipulation, neuromeningeal manipulation, and visceral applications for pediatrics, both in the USA and internationally. Jean Ann Zoller's career, characterized by her innovative approach, dedication to continuous learning, and her leadership in the field, has made a profound impact on the world of pediatric physical therapy. So with that, I'm going to go ahead and stop share. And Jean Ann, I'm going to hand it over to you. Thank you so much for presenting for us tonight, and you are good to go. Oh, I did mute you. Oh, yep, you got it. Thank you.
Get the slideshow. Okay. Hi, everybody. Thanks so much for coming. So I'm going to be talking about visceral neural manipulation in pediatrics, and happy to share this information. My hope is that more people will be able to listen to children and use some of this work that has been so helpful. So some of the goals and objectives of this presentation is to introduce the visceral and neural manipulation for babies and children, and especially applications in things that we see a lot of: reflux, colic, gassiness, irritability, constipation, torticollis, plagiocephaly, and tongue tie. And I will be sharing some case studies and one particular one at the end. So first of all, what's really important to know is our whole body is connected. So if you look in this illustration, let me just get my laser pointer on here. So everything in the body is connected. So our organs, all our organs and the fascia around our organs, including the brain, connect to each other, and the nerves, all the nerves of the body and the spinal cord and the brain connect to the muscles and the ribs and the spine and the brain. So it's important. Motion is essential to life. Tissues in good health have good motion. As we move, our organs move, our nerves move, our blood vessels move. So we need to learn how to help people that have restrictions. And so I have a picture from this section about what a restriction is. And a restriction is a tension or shortening within the tissue, often in the fascia, in and around a structure. These are all restrictions, okay? Like an organ, nerve, muscle, joint, artery, or vein. So restrictions are areas of the body which are tighter and thicker and denser. And restrictions are just like any scars you have. So these areas do not move well. So causes in babies and children can be surgery, can be abnormal brain activity, can be infections, toxins, medications, poor diet, trauma, like birth, and also in utero compression, which we see a lot, falls, accidents, emotions, posture, and overuse. So these restrictions can contribute to the lack of mobility in the whole body, joints and muscles. They can contribute to pain, digestive issues, swallowing issues, elimination, urogenital, and breathing problems. So first, what are the viscera? So for people who haven't had any experience with visceral manipulation, I'm starting with this. So we have organs in the cranium, the brain, okay? We have organs in the thorax, the lungs, and the heart. We have organs in the abdomen, the liver and the stomach and the intestines. We have organs in the pelvic region, the bladder and such. That these are all organs in the body, viscera. So visceral manipulation is manual, very gentle manual therapy. Even though the term manipulation can sound harsh, it's a very, very gentle. We use the word visceral manipulation because that's the word they use in France. So it's a gentle manual therapy for the organs so that the organs move and function better, so that the musculoskeletal structure is going to function better. So things like I'm working a little bit with the liver and the stomach with this child. I'm working with the inferior part of the tongue associated with the cranium, working with the heart and the occiput. Neural manipulation or manual therapy. First of all, we need to know that the brain and the spinal cord are surrounded by meninges, and it's the connective tissue of the nervous system. And these meninges are connected to their container or the bony container of the skull and the vertebral column. And these peripheral nerves are passing through all the muscles and the joints and the fascia, and everything is connected. So neural manipulation is also gentle manual therapy that helps to free up the nerves and the connective tissues around the nerves, the brain, the spinal cord, like the dura mater and the bones around the brain, so the nervous system functions better. For instance, working on some of the bones of the frontal bone here of the skull, working on the falx cerebri of this baby, working on the spinal dura, also going all the way down into the nerves of the feet. So what's different about this approach? So visceral and neuromeningeal manipulation is guided by listening. And so we're going to talk a little bit about listening. And it's very specific, meaning that it is very tissue specific. There's no protocol of what we're doing. We listen to the tissues and we work with the tissues, both the neuromeningeal tissues and also the visceral tissues. And even though it's specific, it's kind of like having a camera that has a zoom out and zoom in feature. So even though you're going very specific, you're never forgetting the whole of the baby. So it's kind of an interesting kind of way of working. So how can we begin to understand and assess and treat the structures that are involved with these babies and children? So the very first thing is listening to the tissues. And the second, these are very basic, but just to make it simple. The second is knowing your anatomy. And the third in babies and children is treating in the direction of ease. So listening is a receptive palpation. So we talked about what a restriction is. So when you have a restriction, now our listening hands will draw our hands passively into the restriction. So in order to listen to the tissues, you must be quiet and present in your mind and yourself and have a mind without an agenda. And you have to be willing to let the tissues show you the areas of restriction. For instance, I have my hand on the occiput of this baby and the hand on the sacrum. And just by connecting with these two landmarks, these two bony prominences, the baby goes into this side bending. Okay. And that will be more of a restriction in the spinal dura. This is a local listening of this child's cecum, and this is where the cecum is, the beginning of the large intestine. Here, I'm listening on the cranium, listening at the vertex to find where the listening is going. So this is Jean-Pierre Barral, and Jean-Pierre Barral is the founder, developer, and the brilliant mind behind all this work. And says, let the body speak. Only the tissues know. So we're always trying to let the body tell us what's going on. We're not telling the body what's going on. So we'll just take a moment or so to do a little listening practice. So I'm just going to invite you guys to close your eyes. First of all, close your eyes. You don't have to look at the screen. I'll talk you through it. And just let your mind and body just settle and take a deep breath. Put yourself in a state that you're receiving. Like think about a good friend that you're just sitting back and you're going to listen to that good friend. And you're not going to do anything. You're just going to listen. You're going to do this with your dominant hand. I want you to put your dominant hand on the opposite forearm and just don't do anything. Just be present and notice if your hand moves in any direction. And just take a moment, and it may not. And if you feel like you're trying to make something happen, just take a deep breath and let go of trying. So you might feel a listening. If you don't, let's put your hand on your thigh. And again, take a deep breath and let your shoulders go and just notice if your hand gets pulled into a certain place. So that's a listening. We may have something going on in these places, we may not. Now we're going to do the same thing. And what I want you to do is you have your hand on your arm. And now instead of listening, I want you to think about doing something. Like you're going to massage that arm, or you're going to move that fascia around. So it has a different intention, the doing and the listening. And those of you who have been doing this work and you know what this is, but some people on this call probably have never heard of listening. So the difference between listening to a tissue, so listening to a tissue, letting the tissue take you into that area versus doing something to the tissue. And that's the biggest difference in this work versus different kinds of work. So the second one is knowing your anatomy and then treating in the direction of ease. So we're going to take these guidelines and we're going to look at a couple of conditions that we might see. Gastroesophageal reflux, small intestine issues, large intestine issues, congenital muscular torticollis and plagiocephaly, and tongue tie. So gastroesophageal reflux. So it's spitting up, right? So up to 2 months, some spitting up is normal. And the sphincters up to the age of 2 months in a baby, the sphincters in the neurological system are immature. So you expect some spitting up, but not too much spitting up. If it's excessive spitting up, oftentimes it's indicating a dysregulation of the autonomic nervous system. And that's the first thing that we work with babies is their autonomic nervous system. And you also might need to check the stomach all the way up to the cranial base for esophageal and vagal nerve tensions. There might be something going on even in the lungs or the diaphragm or the pleura because the esophagus has to move through these structures. Oftentimes, reflux is found with twists and compressions in the body. Another thing is if your baby is constipated, it can cause a backup in the digestive system. So if you look at this illustration, so what anatomy can be restricted? So first, I'm just going to show you that this tube right here is the esophagus, and the esophagus is continuous with the pharynx. And the pharynx, the back of your throat, behind your windpipe, the trachea is connected into the cranial base, into the occipital base, the sphenoid, and the petrous part of the temporal bones. So if there's reflux, it can cause tightening in this area. So we can't, as Jean-Pierre says, you can't imagine doing something in the cranium without working with the entirety of the body, particularly the viscera. Another thing that can be restricted that is very common is called the jugular foramen. The jugular foramen is between the temporal bone and the occipital bone and is located right here. And that is important because the vagus nerve on both sides comes out of the jugular foramen as well as other structures. And the vagus nerve is very important as it's regulating most of the organs in the body, particularly, of course, the lungs and the heart, the stomach, and the first part of the intestinal system. So if there's tension and compression around the jugular foramen, that can cause reflux. It's very, very common in babies. So when we check with, we're assessing for gastroesophageal reflux, we want to check the regulation of both the baby and the parents and attachment. And that's a whole big thing that we can't kind of cover everything in this 1 hour. So, and then the important thing before you do anything is connecting with that baby and child. So before you even do what we do in visceral work as general listening is that you need to have a good connection with that baby and child. So for instance, this is an example of a baby different kinds of babies that have reflux. So I've already connected with the mom and the mom is holding the baby and I'm listening to the baby. And this little baby's listening goes into the nervous system. So general listening is a tool that we use that where is the most important structure in the body that's being affected. And this baby's nervous system was being more affected, so more into the nervous system. And so also listening to this baby at the nervous system, at the occiput, down to the sacrum. And then if we're listening at the vertex, if the baby is allowing us to touch their head, and sometimes that's not the first time, you get a listening perhaps to the jugular foramen. So that's an example of maybe something you would see with a baby that has gastroesophageal reflux. So the treatment would follow the assessment. Of course, first, if there's a regulatory issue, you're going to be working with that. And mechanically, we might be working with the jugular foramen between the temporal bone and the occipital bone. We might be working with the superior pharyngeal constrictor, which is the posterior superior part of the pharynx, and how it attaches into the cranial base. We might be working with the jugular foramen in relationship to the nerves around the heart. So that sometimes it's more neural structures and sometimes more visceral structures. This whole twist might be affecting what's going on with that baby. So we might be working with a twist in the spine. So another example of somebody that has gastroesophageal reflux, another example is, let's say you're listening, you're doing a general listening, and the listening is going now down into the stomach. So now the local listening will be more at the stomach. And so you can see here, the liver is covering a lot of the stomach in the newborn. But our treatment might be something like working with the liver to the stomach, might be working with the gastroesophageal junction to T10, T11. And that's a cutie little guy. So another thing that we might see are small intestine issues. So we might see colic, gassiness, poor sleep, and irritability. So what is some of the anatomy? If we go back to what is the anatomy that may be restricted? So it might be something in the small intestine. Okay, it might be something in the small intestine. It also might be something in the vagus nerve. So again, the vagus nerve is innervating the small intestine. It's more the right vagus nerve in this case. But we also have the sympathetic nervous system. So this is a side view of part of the sympathetic nervous system that might be contributing to what's going on, and it might be some of the nervous system plexuses. So when we're looking at some of the aspects of the small intestine, we need to check for an inherent motion of the viscera, which is called motility. And so we have a motion that's called inspire and expire. And so we check for that. And that also gives us so much information about the nervous system in the small intestine, particularly like there's millions of nerves in the small intestine. It's such a second brain or first brain, some of us might say, but for the whole enteric nervous system. So small intestine motility can give us so much information about how that baby's nervous system is regulating. So we might end up doing a treatment depending on the listening. Some of the possibilities would be working with the small intestine motility. It might be working with the small intestine to the lower thoracic and upper lumbar vertebrae. My posterior hand is on the low back there in that area. It might be working with the jugular foramen or other aspects of the vagus nerve. So these are just, some ideas. And of course, each baby is different. So when we look at the large intestine, sometimes some of the issues with large intestine, of course, constipation, echoparesis, which is fecal leakage, and stool withholding. So again, we will look at the anatomy. What's the anatomy that may be restricted? Again, the large intestine that starts on the right side of the cecum, ascending colon, the transverse colon, the descending, the sigmoid. So it might be something in the large intestine. It also might be the jugular foramen with the vagus nerve. So the first part of the large intestine is innervated by the vagus nerve. The last part is innervated by the parasympathetic is by S2 to S4 from the sacrum, and also the sympathetics from L5 to L2, T5 to L2. So we might be working with small intestine motility. If there is a cecal issue, we might be working with mobility of the cecum. And I use this one quite a lot, working with the sigmoid to the sacral plexus, or sometimes the hypogastric plexus to the sacral plexus to help with the regulation of the autonomic nervous system. So I'm going to show a video, and this baby will be crying because this baby has had uncomfortable digestion. And what I'm going to tell you is that mama is super, I hope I can show this video. No, it's not showing. Let me see. Oh, here we go. The mom is super connected to this baby, and the baby was okay with me doing stuff if the baby was just uncomfortable. So here we go. Maybe.
Hey, Jean Ann, I think this could have something to do with that pointer, the laser pointer that you're using.
Oh, okay. Let me try to remember how to get. Oh yeah, I know. I go to this thing.
The
You go back. Let's see. How do I get out of that?
Actually, it looks like you can play right to the left there. You might be able to hit the play button after all.
Oh, okay. So the baby's uncomfortable, has a lot of gas, really uncomfortable. The mom is doing. I'm on the hypogastric plexus.
There you go. The gas just went.
And the
There
sacrum.
you go. There you go. Oh. Okay. Is that better?
So it goes on like that. So the thing is recognizing that, let me just go back, that oftentimes, babies cry and they have discomfort. I saw a little one yesterday who, unfortunately, the mom had gotten, it was just a 2-month-old, the mom had gotten mastitis and couldn't breastfeed. The mom was a midwife and was really tuned into the baby. And the baby was really uncomfortable and she was so stressed because the baby wasn't gaining weight. And as soon as we were able to clear, I started to do some of this work, and the baby had this huge poop and was like, and on and on and on and on. And finally, the baby was more comfortable, but because the baby was being wet nursed by other mothers, the baby's digestive system was just really confused and not comfortable. So you can help with this work. We're going to go on to congenital muscular torticollis. So congenital muscular torticollis is by definition, is a shortening and tightness of the sternocleidomastoid. So when it's tight, you have a lateral flexion to one side and rotation to the opposite. You can see it more here. Typically, it's caused by if the baby has been compressed in utero, there's not enough room for the baby and they get compressed, and then they can have that tightness that's remembered in the body. It also can be caused by birth trauma, and it can be perpetuated by sleeping on their back, because once they're sleeping on their back and they don't have head control, it'll go into that asymmetrical posture. So it's important to listen through the whole body beyond the sternocleidomastoid, essential, because you can find many, many things in the body that are visceral, neural, spinal, cranial, shoulder, and hip issues. So not just the neck. The memory of the in utero malpositioning is carried within the nervous system, within the dura. So we're going to talk a little bit about that. Every baby that comes into that has congenital muscular torticollis is different. They have different tightnesses, different aspects, different neural structures, different visceral structures that are tight. All these babies are different. Like this baby, when a baby is compressed in utero, and this is pretty extreme, but this baby has compressions in the cranium, particularly the right side, the tentorium, a lot in the cranium, the right side of the neck, of course, the right shoulder, but also the lung, also the right diaphragm and the kidney, also the anterior part of the hip and the posterior part of the knee. All of that has been compressed in utero. And so it's important to listen beyond just the muscles. We have to remember that the musculoskeletal postural deviation is nervous system tightness. So the nervous system. So I drew in, like, this is the spinal dura, and here we have the brachial plexus, and here we have the lumbar plexus, and here we have the femoral nerve. So the nervous system and its fascial container is continuous. It's continuous in the body, so it holds the memory. So if you can work with the nervous system, you can really help these babies. We have to know that it's complicated in the neck. There's a lot of different structures, a lot of nerves. There's a lot of different arteries. There's neurovascular anatomy. There's the trachea and the esophagus. There's a lot in the neck. So one thing that we can do, we want to treat in the direction of ease or where the body wants to go. So for instance, I'm on the occiput here and on the sacrum, and you can see this baby has a twist and turn through the body. And if you're engaging into that twist, and you can go even more into the twist, so you don't just hang out there, but go more into the twist, and you're working with the neuromeningeal system, it can really release quite a bit to get the big twists out at the beginning. This is another little guy. Let's see if I can play this one. Let's see. I'm going to try to take the pointer out again, Justin.
So I'm feeling a little pulse still behind.
So this is a little guy that had a little bit of torticollis and a little bit of latching issues, a lot of compression in the body, and I was just doing a simple, and the baby had a big compression around the posterior right rib at C7T1. And so I was working with that compression going into the direction of ease. Oh, sorry, the videographer missed the head. A little bit left. Just a little bit more in the rotation. There you go. Oftentimes you see a big yawn after something releases. It wasn't the only thing with this baby, but it was a piece of it. Okay. So another thing that you might see, and this is partly what I was doing with this little guy, but not directly, the brachial plexus is a really important structure, and it goes between the clavicle and the first rib. It can get really compressed between the scalenes. The scalenes oftentimes get tight with kids with torticollis. This whole area can get tight and compressed, and so the baby ends up having tightness in that upper extremity. So it's helpful if you know how to work with the brachial plexus to be able to work with the brachial plexus. Another thing is the vagus nerve, our big vagus nerve that goes down, follows the esophagus into the abdomen. And oftentimes when kids have torticollis, that vagus nerve is also tight and compressed. And so babies also have reflux. And that perpetuates the spasm and also perpetuates a cranial dural tightness. The occipital dura is innervated by the vagus nerve. So the vagus nerve can help with a lot. Another thing is with torticollis, we often have different kind of cranial asymmetries. So for instance, there's different kinds. This child has more of, they call it brachiocephalic or more flattening across the back. This one is more plagiocephalic or plagiocephaly, and this one is more scaphulo. So it's more narrow across. So there's a lot of different shapes that we see and that we need to work with. So restrictions can be within the bone, like they can be interosseous restrictions within the bone as the occiput was forming. There can be compressions, separations, there can be compressions at the condyles. There can be compressions and tightness at the sutures or at the fontanelles. So the fontanelles can be compressed. There can also be tightness in the dural membranes, the falx and the tentorium. So it's important to listen to these structures to know what kind of issue is going on in the cranium. A big one, as we said before, is a jugular foramen, because not only is the vagus nerve coming out of there, but also the accessory nerve to the sternocleidomastoid and the trapezius, the glossopharyngeal nerve, which controls swallowing, and the jugular vein. So neuromeningeal manipulation frees whatever structure may be involved. For instance, this little one, I was working on the posterior part of the falx. On this one, I was working on the bones of the back of the parietal bone and the occipital bone. And here I was working on the left tentorium. So depending on what structures are involved. So a big one that we see is tongue tie. Ankyloglossia, so it's a shortening of the lingual frenulum. So here we have a normal lingual frenulum, so the tongue can move up. We all have frenulums. It's just a matter of how tight they are. They impact breastfeeding as well as causing dental issues and potential speech problems later. So oftentimes there's a lot of frenotomies or cutting or laser cutting of the frenulum. There's been a 5-fold increase in the number of frenotomies in the United States between 2003 and 2012. And there's runaway rates of frenotomies for infants also in some Canadian territories. There's lots of articles. I just have some of the articles in the references. So an anterior tongue tie is fairly obvious, and typically, historically, midwives would clip the tongue as a newborn. The posterior tongue tie is more controversial. So we'll look a little bit at the anatomy. If it's too much, just sit back and hang out. So there's different muscles that go, extrinsic muscles that go from the tongue to the hyoid bone and to the skull. So the palatoglossus goes from the tongue to the soft palate. It elevates the tongue. The genioglossus goes from the tongue to the mandible. And the hyoglossus goes from the tongue to the hyoid bone. And the styloglossus goes from the tongue to the styloid process. So these are just some extrinsic muscles. But what other anatomy can be restricted? So we have to know that oftentimes it's fascia that's inferior to the tongue and posterior. So we look at the genioglossus, we look at the geniohyoid, we look at the stylohyoid muscle and ligament. And a really big one is the pharyngobasilar aponeurosis and fascia that's going from the posterior part of the pharynx into the occiput, the sphenoid, and the temporal bone. So here we have the superior pharyngeal constrictors, and it's complicated anatomy, but just know that behind all of this and in front of your occiput, that can get very, very tight. And we oftentimes see the occiput coming anterior because of all this deep fascia. So just some anatomy pictures. You can see that I have arrows in the position, the angle of the tightness here. This is looking from the inside of the mouth, and here is the back of the pharynx, and you can see the fascia and that goes back into the sphenoid and the occiput, as I said before, and the petrous part of the temporal bone. So all of this can pull on the base of the cranium. So the assessment and treatment, again, depends on your listenings. So these are just some examples. So superior pharyngeal constrictor, pterygomandibular raphe, if you know what that is, the buccopharyngeal fascia, all big names, but connections between the tongue and the back of the head. This is more of the posterior tongue going externally to the styloglossus. This gal, I did a little bit of an internal one. This is an older gal, medially and superior, and the hyoid inferiorly. So these are just some things that we work with. And it's really great if you're able to get the baby before they have a tongue tie release so that you can free so much up, because this will all still be tight and then there'll be trauma afterwards. So I'm just going to give you a quick, this is from my book. And this little guy, Flint, he's hiding because he's shy. He's a 2.5-year-old with mouth breathing and snoring and holding his breath, constipation, a little bit of bedwetting, and he got very tired. So he was really shy and he needed to be close to his mom. This is just a little bit of what his case study looked like, and he wouldn't make eye contact with me. He was born during COVID, and his mom had postpartum preeclampsia and had to be hospitalized. But the mom, the father took the baby home and went back and forth and brought breast milk to Flint. And after the mom was discharged, he had some latching issues, but she was actually able to breastfeed him until 18 months of age. So first, when I first saw him, his head and neck were slightly side bent to the left and rotated to the right. He was extended in his upper cervical area, and he had a lot of tightness in his throat. His listening and general listening went to the superficial cardiac plexus, and also there was listening to the lesser curvature of the stomach and also to the left side of the neck. The motility of his small intestine and his stomach were low, and his cranial rhythm had a very low amplitude. So first, he felt really safe with his mom, but didn't make eye contact with me. So I did a lot of trying to establish connection, and that is a lot about working with part of the vagal system, the ventral vagal system. And this is an illustration from my book just to show the superficial cardiac plexus and how the vagus nerve is innervating the heart. That's part of the innervation. And so because of the separation at birth, the local listening went to the superficial cardiac plexus. It was important to augment the connection between his mother, the mom and child, even though we know that they're connected, but just to help physically with his body. So I would connect both of them from their heart and from heart to heart while she was holding him, and between that and T2 to T4. And he started calming down and took some deeper breaths. I like to make them feel comfortable with me. And so sometimes I don't go with the listening. I go with where they feel comfortable. And they like to push the therapist over with their feet. And then you give them a little bit of deep proprioceptive input. And so he was pushing me away. And then he finally started laughing and making eye contact. And then we continued with this, and he started feeling a little bit more safe with me. So then I started working indirectly with his vagal system, and I still didn't work with his listening. I'm working more with his cranial system through the sacrum and working with his intestinal motility. After that, the second session was 3 weeks later. His mom said he was tired, he was still constipated, and his posture was about the same. And he came in and he connected more with me. So I knew that he was more with me and I could do some more work with him. And this is really typical, especially with babies and children who've had any kind of procedures or have had separation from mom, any kind of surgeries, tongue tie. So this is why I brought this case study here. So I worked again with connection and regulation, and he moved more through that and allowed me to go ahead and start working more with his vagus nerve. And so I worked with his lesser curvature of his stomach. I worked with the sympathetic superficial cardiac plexus and T2 to T4. And then I started working more directly with his vagus nerve from the occipital mastoid suture. His head was really sensitive on that side. So I worked a lot in connection with the superficial cervical plexus and the stomach, and then working with the nervous system, a balancing plexus, and then always giving time so he can play and integrate. The third session was 1 month later, and Mom said his constipation was much better and his bedwetting had improved, which I attribute to his nervous system starting to come back on board and feeling better. His neck posture was better, but there was still some lateral flexion. And he was much more willing to get treatment. He went on the table. His listening was still to the superficial cardiac plexus and to the left side of the neck and jugular foramen. And we moved through to these treatments, and he let me work more and more with him. So I was able to really start getting into some of this fascia in here, some of the compression that he had in his cranial base. And he ended up being, he ended up being the kid is on the front of the book because he came so far. And part of it is just a wonderful family. And but just that he was able to kind of get out of his shell and really socialize and integrate and play more. My goal is always to get more expansion of that child so they can be more expanded in the world. So subsequent sessions, I saw him about once a month for 6 months, and his breathing and snoring started to improve. He got better. He began to use a little bit of a Myo-Munchie chewing device, and he started doing some tongue exercises, and he became more at ease. So this is my conclusion about him. His primary issue was more dysregulation of his ventral vagal system, and he had compression. He had mechanical compression that was contributing to that of his cranial base and his upper cervical spine and his left vagus nerve and his superficial cardiac plexus. This, coupled with the separation from his mom for 5 days after the birth, affected that ventral vagal system, which is your social engagement system, which affected his digestive system and his urogenital system. So even though his mother was very regulated and responded quickly to his needs, this system had to be treated for him to have changes. So just in conclusion, development of touch and perception takes, a lot of training, but it takes a lot of study and practice. And as Jean-Pierre told me a long time ago, start and practice on adults first, and get your hands good before you work on the little ones. And again, using different kinds of touch that help cranial sacral therapy, myofascial release, total motion release is a great manual therapy, and visceral and neural manipulation. And just remember, the intelligence of our hands with the observations will always guide us to help our little ones. And I just want to thank the Barral Institute. I want to thank all of you who have been kind enough to come and watch. And I really want to thank the babies and the children and the families who've helped bring this work into the world. Thank you. And I just want to let you know, I do have some references on here, lots of them, because I referenced everything in my book. So I'm not going to go through those so that we can have a little bit of time, hopefully, for some questions.
Terrific job, Jean-Ann. Thank you. Let me just get into here my PowerPoint. So at this time, one thing I'll say is that we don't have an evaluation process, but I see that there's a lot of nice compliments in the chat, Jean-Ann. So if you want to enjoy those, if you'd like to start putting any questions you have for Jean-Ann in the chat, you could do that at this time as well. But I wanted to go over some things that I think that you will find very useful. In the beginning, in Jean-Ann's bio, I mentioned Pediatric Manual Therapy, Visceral and Neuromeningeal Manipulation, Volume 1. That is out. And I know that Jean-Ann had worked on this for many years to get the Volume 1, and then Volume 2 will be released in 2025. So Volume 1 guides the manual therapist through a step-by-step approach to assessing and treating the autonomic nervous system and neuromeningeal system in pediatric patients. It includes case studies that integrate visceral and neuromeningeal manipulation with pediatric therapy. Again, volume 2, which will be coming out in 2025, will continue with assessment and treatment, focusing on the organs using visceral manipulation and further case studies as well to illustrate practical applications. Down here is a QR code. If you're interested in this book, learning more about it, if you pull out your cell phone at this time, you can just put your camera up to the QR code, and that'll give you a link right to our website. We'll tell you more, and if you'd like to order the book, it'll be there for you as well. I'm going to pull up the chat here to just give you a minute in case anybody is pulling up their phone and see if there's any questions. Again, tonight we are going to a couple things. We're going to handle questions through chat, which I already see one has come in there. And then another thing I want to remind you is if you have registered for this presentation, that you will receive a follow-up from our team with the recording. So here's just again, volume 2 will be released in 2025. I'm not going to put on any extra pressure on Jean-Ann right now and give you the exact date, but the plan is 2025 for that. Visceral applications for pediatrics, October 2nd through the 5th in Minneapolis. So if this is a class, you're a trained therapist with us, you would have needed to take visceral manipulation 2, the abdomen 2, and neuromanipulation 1. So VM 1 and 2 and NM 1 are required. VM 4 and listening techniques 1, visceral 4 and listening techniques 1 are recommended. There are still some spaces for 2025 in the Midwest and Minneapolis, October 2nd through the 5th. Now, if you're here because someone referred you and said this might be a good presentation for you, I know it fits into my own personal life well. If you're looking for somebody to help, you need help, our database, www.iahp.com. You can search your area. You can do a radius search of your area, and you can look for practitioners there that specialize with peds, and I would definitely recommend that just from my own personal experience. Upcoming In Touch segments, holiday break, so please check your email or the website for In Touch offerings in spring of 2025. We will be emailing all those who are on our list. And at this point, I will say, if you want to learn more about Brawl Institute's offerings, maybe this is your first time being here with us. This is a QR code. If you pull out your phone, you fill out the little form. If you are a manual therapist, you fill out the form, and we'll tell you more about our trainings. We're in countries all over the world, and we're in pretty much every major city in North America operating for the Brawl Institute. So if you do pull out your camera there, if you missed this for whatever reason right now, you can get that on the recording that'll come your way, or you can email me directly and I'll be happy to help however I can. And then lastly, we always not before, we're going to go back to Q&A, don't worry, but lastly, we always post our In Touch presentations on our Facebook page. So if you're not following the Brawl Institute Facebook page, I think you'll find this posted tomorrow. If not tomorrow, then the next day. Sometime this week, we'll get this posted for you. You can always review it there. If you have any nice words you'd like to leave for Jean-Ann, you can do that there as well. So I think we do have some time for some questions. Let me just see if I can come up here. There's a lot of really nice. Let me get you on screen here, Jean-Ann. And I will look for questions if you haven't already found a few.
Yeah, there's a lot of questions. Can you hear me still?
Yep, we're good.
Okay. All right, there's a lot of questions. So let's see.
I think I can probably help you here, Jean-Ann. Is there a time that is too late for the tongue tie as an adult teen? Or excuse me, as an adult teeth?
As an adult teeth?
Is there a
Well,
time?
they're always doing there. Is there a time that is too late for them?
Yeah, would it be too late with adult once the
No,
adult?
I mean, a lot of adults are also
I think I'm sorry, I didn't read that well. I think the question was once the child has their adult teeth in. You can
yeah.
correct
It's
me if
harder. It's harder. It gets harder as they get older. It gets harder as they get older, but you can still work on adults, of course. So, that you can still work as long as the kid is going to let you work on them. You can work on them whenever. It's just going to be more effective when you're little. I think I'm going to go through and choose some questions.
Okay, very good.
So there's a question is how may I know the feeling how should we feel when we are doing general listening and then local listening? Is the feeling different in assessment and NM treatment? So general listening is the same as when you're doing it with an adult in a certain way. It depends on the first couple of months before they can hold their head up. You're doing it more in supine. Oftentimes I'm listening through the body, all the way through the body, because the baby is small and you can feel the general listening. Once they're able to hold their head up and they can be on their parent's shoulder, then you can listen from the head. And again, this general listening is pulling you into where the area of most greatest concern, as same with local listening. So that's the same. Just those first couple of months. Let's see. So there's a question is, what areas you often work on when you have a child with strong extensor tone with arching. So it depends on if that's a neurological issue, if that's coming from reflux, because reflux can cause quite a bit of extensor tone, as well as arching from a lot of different things, like a premature baby that's been in the NICU has been an extension a lot of times. So it can be in the nervous system, in the dura nervous system. It can be, let's see, I'm just going through kids in my mind. If it's reflux, it's everything that I described, depending if it's more neural or if it's more visceral, but oftentimes it's the autonomic nervous system, sympathetic or parasympathetic. Bedwetting is hard. There's a question about bedwetting, and bedwetting is hard because oftentimes it's involving not only the autonomic nervous system, but emotional issues. And like I had a child who was very, very shy, very quiet, and she was bedwetting. She wasn't wetting at school. She had homeschooled, had a lot of different kids in her family, like 8. And when I checked her, all her motilities were shut down. So when all the motilities are shut down, to me, that means a shut down autonomic nervous system. The whole vagal system is shut down. And so I had to work a little bit differently. I had to do some problem solving at how she could have some space to herself and how she could start to connect socially. So that, oftentimes that's like the listening can take you into other things. And oftentimes you have to work with the autonomic nervous system and the kidneys, especially the adrenals. You can work with the make sure the skeletal structure that's innervating the urogenital system is freed up, particularly around the sacrum and the thoracic and lower lumbar spine, but usually that's not as frequent for me, what I see. Let's see. So objective criteria to evaluate effectiveness of these patients. So it depends on what you're evaluating. So if oftentimes, just like as in any kind of pediatric therapy, you're being looking at development is a big one, looking at range of motion. I like to look at active range of motion. And so I'll do sometimes passive range of motion, but I'm careful with that with the neck. So you're looking at how they are, like if they have torticollis and they're, 7 months, are they propping and prone? Are they symmetrical? I take a lot of photos, especially of the head and the neck, because it's really hard to document plagiocephaly. I have my folks at in different places that do cranial molding orthosis or helmets. They take the measurements free. So I don't have to take the measurements, but you can always take the measurements of the head. So there's a lot of ways to document, and it's important to document whatever it is clinically, if it's swallowing and they're not eating, like if they're able to start, eating a certain kind of food because of the work that you've been able to do. So it really depends. It's a very general answer. Let's see. So what specific protocols do you follow to reduce meningeal tensions? And I'm not sure if that's something for in this work, it's always working in the direction of ease first and letting the body take you into the direction of ease and not into a direct stretch. That's really important because if you there's so many nerves, particularly in the neck, that if you overstretch, it could go into spasm and into more muscular spasm. So always working with listening is the biggest thing that I do. And I haven't caused harm in a baby or a child that I am aware of at this point. So let's see. Because it's manual therapy, it's gentle manual therapy. Yeah, so what are the experiences regarding the contribution of neuromeningeal manipulation to the functional gains? Again, oftentimes kids come with various neuromotor, neurodevelopmental issues. Usually it's asymmetry. Usually it's something like, it could even be something with like an older kid with running. So depends on what the functional outcome is, what you're testing to know what the gains are going to be. So you could do this with any kind of manual therapy or any kind of your treatment. So it's anything that you would do as a pediatric therapist, depending on the function. Let's see, I'm going to go down a little bit. Really good question from Kirsten. Hi. Do you have had time frame when you start working with baby that needs cranial orthoses, or do you wait initially, or you can start right away? So if I can get the baby as soon as possible, when they're after they've been born and they're settled back at home, and the earlier you can get the baby, the better. Typically, they don't even want to put on a molding orthosis for till after 4 months. So if you can get them the first 4 months, you're great. When they're when they're using the molding orthoses, it's always good to do the work during that time. So I try to get as much as I can, but it really depends on the level of the level of plagiocephaly. And sometimes the plagiocephaly is so intense. I had one little guy who I really wanted him to get a molding orthosis, and the family wouldn't let me. And I was like, oh, so I had to do so much work to be able to get that baby. And he did well, but it was a lot of manual therapy to get him. In torticollis, how often do you find cranial base or condylar restrictions? And that's part of it. I do find that there is cranial base, condylar restrictions. Yep. Especially that and with tongue tie. Not the only thing. Upper cervical spine neural fixations are big. Vagal nerve restrictions are big, but cranial base is very, very often. Let's see. I think that might be.
Yeah, we are on the hour, Jean Ann, so I don't if
Yep.
no, okay, very good. Well, I'm just gonna say thank you again to everyone who's attending, and I want to leave the floor with you, Jean Ann, for any. I know you're probably gonna say, well, I've said a lot, but if there is there any final thought before we conclude for this evening?
I'm just putting my email on there. You can email me. I'm happy to try to answer questions from, just go ahead and email me. It's fine.
That's very generous and gracious of you. So go ahead, Jean Ann, anything
Yeah, I
else?
just want to thank everybody. This it's quite a body of work, honestly, to work with these little ones, and they're always challenging. They're always challenging us and teaching. I learn every single day from these little ones. So the more, if you're able to work with these little ones, you can change their lives. You can really help open up their lives. Any pediatric therapist does. And so I just hope this adds to your work, and I hope to see you in classes sometime.
Awesome. Very good. Take care, everyone. Thanks again, Jean Ann.
Thank you.